Okay, good evening, everybody. This is Dr. Arnab from Nice Hospital, Hyderabad. Today, our speaker is Dr. Radha Reddy. She is one of our DRNB neonatology resident, and her talk is on the approach of antenatal hydronephrosis. With increasing use of technology and TIFA scans, it is quite common to find out antenatal hydronephrosis in many of our fetuses. So her talk will address the issues, how to approach that, as well as those children who continue to have hydronephrosis even after birth. So Radha, you can start your talk, please.
Yes, sir. Good evening, everyone. Today, I'm going to discuss about the antenatal hydronephrosis, how to approach this. And I'm going to cover regarding the definition and etiology, the grading of fetal and antenatal neonatal hydronephrosis and diagnostic studies, and how to manage these antenatally diagnosed as well as postnatal management. Coming to the introduction, antenatal hydronephrosis is found in 1 to 5% of all pregnancies, and it is most commonly detected prenatal abnormality. It is twice as common in boys and can be bilateral in 30% of the cases. So the presence of bilateral obstructive process and in the presence of bilateral obstructive process, oligohydramnios is the best predictor of an adverse outcome. The timing of oligohydramnios is important determinant of the fetal outcome. The earlier the lesion develops, more likely it has effect on fetal kidney as well as lungs, and also overall fetal outcome is determined by the presence of oligohydramnios and the onset of the lesion. Coming to the definition of hydronephrosis, dilation of renal pelvis with or without dilation of renal calyces is termed as hydronephrosis. Currently, the term urinary tract dilation is proposed under the congenital abnormalities of kidney and urinary tract. And a single grading system that can be used across the prenatal and postnatal time period to describe the urinary tract dilation is a UTD grading system. And coming to the etiology, antenatal hydronephrosis can be caused by a variety of congenital anomalies of kidneys and urinary tract, which can be grouped into urinary obstruction, vesico-ureteric reflex, and non-obstructive dilation or transient dilation. The rationale of these prenatal detection is mainly to identify the pathology prior to the development of complications such as UTIs or stone formations or renal impairment. Coming to the multiple causes, the most common cause is transient hydronephrosis. The transient hydronephrosis is almost 41 to 88% in incidence, and 80% of these cases resolve spontaneously, and the hydronephrosis which improves or resolves during pregnancy is unlikely to have any prenatal implications. So this transient hydronephrosis can be due to delay in maturation of the ureter, leading to transient urinary flow obstruction. This type of hydronephrosis usually resolves within 2 years of age. The other second most common is ureteropelvic junction obstruction, but this is the most common cause of moderate to severe hydronephrosis. And this can be due to incomplete recanalization of the proximal ureters and abnormal development of the ureteral musculature or abnormal peristalsis or any cause of polyps. And this ureteropelvic junction obstruction is most commonly associated with other congenital abnormalities also. Coming to the vesico-ureteric reflex, it is nothing but the retrograde propulsion of the urine into the upper urinary tract. And this could be due to ectopic insertion of the ureter into the bladder wall or leading to short intravesicular ureter and leading to the reflux. And this have the grading system based on the severity, which is discussed later in the slides. And the other cause is a ureterovesical junction obstruction or the megaureters. This is due to deficient development of the distal ureter or presence of ureteroceles. 70% of the cases resolves spontaneously, But ureteric dilatation more than 1 centimeter is associated with recurrent UTIs. Multicystic dysplastic kidney also like 4 to 6% of incidence, and the other is a posterior urethral valve. This is most common cause of hydronephrosis in the male babies, which have an incident, 1 in 5,000 cases, and it is composed of it is due to a presence of a membrane that obstructs the urinary flow. This membrane formation could be due to failure of regression of the mesonephric ducts. And most uncommon causes are the prune belly syndrome, which is also known as Eagle-Barrett syndrome, or cystic kidney disease, or congenital ureteric strictures, or the megalourethris. Eagle-Barrett syndrome is nothing but a triad of genitourinary abnormalities with abdominal defect in the muscle, abdominal muscle defects, and cryptorchidism. Coming to the pathophysiology of the uretero-pelvic junction type of hydronephrosis, we all know the kidney has two components, the parenchyma and the pelvic calcium system, which has suborgans like cortex and medulla, and pelvic calcium is the pelvis and the calyces. Each part affects and behaves differently as a response to this uretero-pelvic junction obstruction, depending upon the severity of the hydronephrosis. Coming to the renal pelvis, the renal pelvis has high compliance, hence enlarges significantly to protect the renal parenchyma. Even with minimal increase in pressures, there will be significant dilation of the renal pelvis in order to protect the renal parenchyma. Coming to the calyces, the expandability of calyces is lower than that of the renal pelvis, and the dilation of calyces means a greater degree of risk of hydronephrosis. And even the dilation of calyces is in order to protect the renal parenchyma. Coming to the medulla, medulla is similar to the lung tissue. It is more expandable and compressible rapidly, depending upon the degree of stenosis and the time interval. The medulla becomes shorter and loses its pyramid form with normal renal parenchymal and normal renal parenchymal thickness is 7.5 mm. Coming to the cortex, the compressed and thinned cortex is suggestive of renal damage. Cortex, usually the texture is similar to that of liver. It is harder compared to the medulla. So hence compression of cortex indicates significant renal damage. The loss of more than 50% of the cortex is mostly associated with renal atrophy and irreversible renal damage. So always the thickness and the appearance of the renal parenchyma determines the severity of the hydronephrosis. Coming to the grading systems, there were multiple grading systems, which includes anterior-posterior diameter of renal pelvis, SFU grading system, radiology grading system, UTD classification, and ONN grading system. Coming to the AP diameter of the renal pelvis, this is the most commonly used method to define and grade the fetal hydronephrosis. And this AP diameter is measured in the transverse plane. And fetal hydronephrosis is graded according to this during especially during the second and the third trimester of the pregnancies. The APD is very dynamic parameter, which can be affected by the hydration status of the baby. Also, the epidiameter is low in empty bladder, and also varies with the respiration and the position of the baby. And its operator differences is also very high. These are the limitations of this epidiameter. Usually it is used only in the antenatal assessment, not in the postnatal. The classification of hydronephrosis antenatally depending upon the APD into mild, moderate, severe. In the second trimester, 4 to 6 mm is mild, 7 to 10 mm is moderate, and more than 10 mm is severe. Coming to third trimester, 7 to 9 mm is mild, and 9 to 15 is moderate, and more than 15 is severe hydronephrosis. Coming to SFU grading system, the Society of Fetal Urology grading system, it is developed in 1993. it is also quantitative and subjective. And this grading system is based on degree and site of pelvic dilation, number of calyces seen, and the presence and severity of the parenchymal atrophy. The SFU grading system mainly focuses on the degree of hydronephrosis in the kidney without directly assessing the state of ureter and the bladder. This is a SFU grading system. We can see the grade 1, the urine barely splits the sinus. Here the pelvis and the major calyces are involved. And in grade 3, the uniformly dilated minor calyces is seen and parenchyma is intact. And coming to the grade 4, here we can see the thinning of the parenchyma, which indicates severe hydronephrosis. Coming to the radiological grading system, this is a partially modified SFU grading system, which includes the APD diameter also. In radiological grade 1, just renal pelvis is visible with APD of 5 to 7 mm. And grade 2, some calyces involvement is there with APD of 7 to 10 mm. And grade 3, marked dilation of calyces with APD of more than 10 mm. And in grade 4, narrowing of parenchyma, and grade 5, extreme hydronephrosis with only thinning or membrane-like parenchymal involvement is seen, which indicates the severity. Coming to the urinary tract dilation classification system, this is based on 6 ultrasound findings, and which are anterior and posterior renal pelvis diameter, calyceal dilation, renal parenchymal thickness, renal parenchymal appearance, bladder abnormalities, and ureteral abnormalities. The main difference between the SFU and the UTD is it considers both the ureteral and the bladder abnormalities. UTD classification is seen as antenatal as well as postnatal, which includes a low risk and high risk. The UTD postnatal 1 involves pelvis is dilated, and P2 we can see the central and peripheral calyces dilated, and in P3 parenchyma is involved. Coming to the prenatal presentation, when there is a APD of 4 to 7 mm detected at 16 to 27 weeks, or more than 28 weeks with APD of 7 to 10 mm with central or no calyceal dilation, it comes under low risk. And antenatally, with APD of more than 7 mm at 16 to 27 weeks, and more than 10 mm, more than or equal to 10 mm at more than or equal to 28 weeks of presentation with peripheral calyceal dilation and parenchymal thickness abnormalities, as well as appearance abnormality, and ureters and bladder abnormality and unexplained oligohydramnios antenatally. This with high risk. This comes under high risk. And coming to the postnatally, more than 48 hours, APD diameter 10 to 15 mm with central calyceal involvement, it comes under low risk. More than 15 mm with peripheral calyceal involvement and ureter abnormality, it comes under intermediate risk. And more than 48 hours with more than 15 mm, it comes under high risk. This is an ultrasound image which shows a fetal kidneys at 32 weeks of gestation. This is a transverse plane view, which APD diameter is less than 7 mm, which is normal for the gestation age. And the other image is a sagittal view where bladder is not visible, but parenchyma appears to be normal. This is the normal imaging at 32 weeks. And the next image is at 19 weeks of gestation, showing less than 7 mm. And this is at 37 weeks of gestation, a transverse plane, showing less than 10 mm, which is normal for the gestation age. And this is also less than 10 mm, but here central calyceal involvement is there, which is at low risk. And peripheral calyceal dilation is seen, which indicates intermediate risk. And here parenchyma, and the other picture, we can see the thinning of the parenchyma and also the cystic formation, which indicates a high risk or severe hydronephrosis. The risk-based management of this prenatal diagnosis is if UTD classification with antenatally low risk, prenatal period, one additional ultrasound is required at more than 32 weeks and should be followed up after birth after 48 hours to 1 month and 1 to 6 months later, and should rule out aneuploidy risk modification if indicated. And coming to the UTD increased risk, prenatal period initially in 4 to 6 weeks, and after birth more than 48 hours to 1 month, and at the specialist consultation if required. Coming to the risk-based management with a postnatal diagnosis with low risk, we have to follow up 1 to 6 months. VCUG based on presentation, which we'll discuss later, and intermediate risk also 1 to 3 months, and antibiotic also, which will be discussed in the later slides. And high risk should be followed up based on the whether bilateral involvement or unilateral involvement is there. Coming to the ONEN grading system, this grading system has been developed for both prenatal and postnatal. This includes two categories of the kidney findings, mainly the dilation of the pelvic calcium system and the quality of renal parenchymal involvement, that is the thickness as well as the appearance, whether the medulla is involved or the cortex is involved. The appearance of parenchyma, which includes echogenicity, cortical cyst formation, corticomedullary differentiation, which is suggestive of renal damage, is also taken into account in this grading system. Coming to the ONEN hydronephrosis grading system, grade 1, we can see the renal pelvis dilation alone, and APD diameter is not taken into consideration. In grade 2, pelvis as well as calyceal involvement is seen, and in grade 3, pelvis plus calyceal dilation is seen with blunting of the calyces, and also the medulla involvement is seen. Medulla becomes short and thin. Cortex appears normal, and in grade 4, pelvis plus calyces, there is no medulla at all, and we can also see the cortex involvement. Cortex is thin. So grade 4 is like severe hydronephrosis with renal damage. Coming to the approach of the hydronephrosis, when we diagnose antenatal hydronephrosis, we have to inquire about any prior pregnancy complications, any other associated anomalies found in the TIFA scan, and also presence of family history of urological diseases, onset as well as the fetal sex, which is not possible in India, and also associated with oligohydramnios and severity of hydronephrosis. And after birth, the physical examination findings is very important to rule out like approach to different etiologies. So on examination, if you find any abdominal mass, we have to rule out enlarged kidneys due to obstructive uropathy or multicystic dysplastic kidney. A palpable bladder in a male infant suggestive of posterior urethral valve. A male infant with deficient abdominal wall musculature and undescended testes, it is a prune belly syndrome. And any associated outer ear abnormalities, we have to see for increased risk of congenital anomalies of kidney and urinary tract. And a single umbilical artery also suggests of increased risk of anomalies of kidney and urinary tract, particularly the vesico-ureteric reflex. And if a child having any spinal or lower extremity abnormalities, we have to look for any neurogenic plan. Coming to the imaging studies, the imaging studies used for diagnosis of the hydronephrosis is ultrasound, which helps in the grading system, which we discussed before, vesicocystourethrogram, and diuretic renography and magnetic resonance urography. Coming to the ultrasound, it detects most congenital anomalies of the kidney and the urinary tract associated with fetal hydronephrosis without any radiation exposure. And it is avoided in first 2 or 3 days after birth due to extracellular fluid shift that will underestimate the degree of hydronephrosis. And infants with bilateral hydronephrosis and hydronephric solitary kidney require urgent evaluation within 48 hours of birth, as there is possible need for early intervention. Coming to VCUG, the prevalence of uretropelvic junction obstruction with concomitant vesicoureteric reflux in patients with hydronephrosis ranges from 6% to maximum of 10%. The MCU can be performed in patients with unilateral or bilateral hydronephrosis with renal pelvis APD more than 10 mm and SFU grade 3 to 4 or ureteric dilation. It is performed within 24 to 72 hours of life in patients with suspected lower urinary tract obstruction, and in other cases, it should be done at 4 to 6 weeks of age. According to the guidelines of 2010 American Neurological Association and the BUR guidelines of 2012 European Association of Urology, they do not usually recommend for all cases, but recommends only if patients with high-grade hydronephrosis and severe ureteral dilation or history of UTIs. This is a VCOG showing dilated and elongated posterior urethral valve, usually a keyhole sign, which can be detected in the ultrasound as well. Here you can notice the obstruction at the bladder outlet. And coming to the grades of VUR, the grades of VUR in grade 1, where you can see the ureter involvement, and reflex is limited to the ureters here. In a grade 2, the reflex involving the renal pelvis, and in grade 3, there is mild dilation of the ureter and the pelvic calyceal system. And in grade 4, we can see tortuous ureter and dilation with blunting of the fornices. And grade 5, it is severe severe reflex, where tortuous and severe dilation, loss of fornices, and papillary impressions are also lost. The other modality which helps in the approach is diuretic renography. It helps to diagnose the urinary tract obstruction in infants with persistent grade 4 and possibly grade 1 hydronephrosis after VCUG has demonstrated no VUR. It measures the drainage time from the renal pelvis and assesses the relative contribution of each kidney to overall renal function. And this procedure requires bladder catheterization to relieve any pressures that can be transmitted to the ureters and the kidneys, and also requires an IV access for adequate hydration and administration of radioisotope as well as the diuretic. The preferred diuretic is technetium 99 Mark III, as it is taken up by the cortex and filtered across the glomerular basement membrane to the renal tubules and excreted into the renal pelvis and the urinary tract. This renography includes 2 phases. Initial phase, the radioisotope is injected and renal uptake is measured within 2 to 3 minutes, which we can see the split renal function, and it is split renal function is assessed within 2 to 3 minutes, and if the difference is less than 5%, it is normal. And the second phase is a peak renal uptake, which indicates extent of renal obstruction. An injection furosemide 1 mg per kg IV is administered, and excretion of radioisotope is measured, which will call it as a washout curve. Here we can see the curves. This is known as washout curve. We can assess if it is less than a curve that shows an early peak, 2 to 5 minutes, followed by complete emptying, either spontaneously or after furosemide, or on late post-maturation film, excludes the obstruction. So if it is within 15 minutes, it is normal. 15 to 20 minutes is intermediate, and more than 20 minutes is obstructive, indicates an obstructive uropathy. This is a radioisotope scan, which we can see the cortical retention of tracer due to left PUJ obstruction. We can see the retention of the dye in the left side, but complete clearing seen in the left side of the kidney. The role of diuretic renography is in infants with hydronephrosis and dilated ureters with no evidence of VUR, and diuretic renography should be performed after 6 to 8 weeks of age. And the procedure may be repeated after 3 to 6 months in infants where ultrasound shows worsening of the pelvic calcium dilation. The magnetic resonance urography, it is useful in the management of obstructed kidneys that have rotation or ascent anomalies or single kidney. It clearly defines the anatomy and delineate proper surgical approach. And main disadvantage of this magnetic resonance urography is it requires general anesthesia or heavy conscious sedation, the use of contrast agents or gadolinium, which can only be used if the renal function is normal, or else it causes irreversible renal fibrosis. This is an MR urography showing left PUJ obstruction. Coming to the management of antenatal hydronephrosis, as we discussed, the prenatal evaluation and monitoring of fetal hydronephrosis is if RPD more than 4 mm at 18 to 20 weeks, which is we have to see whether it is a unilateral or bilateral. If it is bilateral, we have to look for any associated oligohydramnios there or not. If oligohydramnios is there, poor prognosis, provide counseling and consider legal termination accordingly. And if it is not associated with oligohydramnios, serial repeat ultrasounds every 2 to 3 weeks. If oligohydramnios persists, further monitoring and management accordingly, ruling out the causes of oligohydramnios. And if not associated with oligohydramnios, but RPD is more than 10 mm, postnatal evaluation after 48 hours. If it is not more than 10 mm, usually the fetal hydronephrosis resolves. No further intervention is required. If it is unilateral, you have to repeat ultrasound at 30 to 33 weeks of gestation. And if it is more than 10 mm, postnatal evaluation after 48 hours. And if it is less, fetal hydronephrosis usually resolved and no further workup is required. The additional parameters evaluated on antenatal ultrasound was, we have to look for associated oligohydramnios and calyceal dilation, perinephric urinomas, dilator or thickened bladder, ureteral dilation, any keyhole signs indicating PUVs, loss of renal parenchyma as suggested by cortical thinning or poor corticomedullary differentiation, and also associated systemic abnormalities like major systemic structural anomalies, other anomalies in serious neurological or GI anomalies, and other soft signs like increased nuchal translucency or absent nasal bone or echogenic bowel or hydronephrosis, ventriculomegaly or short and long bones or echogenic focus in the heart. The genetic counseling and testing is also important. They are offered in addition if fetal anomalies are detected in women of advanced maternal age and in women with abnormal maternal serum screening tests during the first or second trimester. Usually the Down syndrome is associated with mild hydronephrosis, and studies that define hydronephrosis as RPD more than 4 mm in the second trimester demonstrated hydronephrosis is greater in downs when compared with normal control fetuses. Coming to the fetal surgery, although there have been several prospective and retrospective studies of antenatal surgery in fetuses with ultrasound findings consistent with lower urinary tract obstruction, there is no good evidence that fetal intervention improves the renal outcome or long-term survival. The increase increase in the amount of amniotic fluid, potentially improving the lung development and the survival rate. So in very rare cases with severe bilateral hydronephrosis due to bladder outlet obstruction from PUV, they consider serial fetal bladder taps for amniotic fluid analysis. And if the prognosis appears favorable, they will perform a vesicoamniotic shunting. The fetal vesicosynthesis done on 2 or more occasions allows estimation of urinary electrolytes, beta-2 microglobulin, and osmolality, which predicts renal maturity and the function. The decreased levels of these parameters identify the fetuses that are likely to benefit from the therapeutic intervention. So, according to a randomized controlled trial that aimed to determine if percutaneous vesicoamniotic shunting versus conservative management for fetal lower urinary tract obstruction improves the survival and the renal outcome. So according this study, they could not able to complete because of less sample size. They have enrolled only 31 cases. According to this study, the survival seemed to be higher in the fetuses receiving vesicoamniotic shunting, but the size and direction of the effect remained uncertain, such that benefit could not be conclusively proven. The results suggest that the chance of newborn babies surviving with normal renal function is very low, irrespective of whether or not vesicoamniotic shunting is done. So coming to the postnatal evaluation, the non-emergency postnatal management, infants are relatively dehydrated at birth. That's why the initial postnatal ultrasound should be performed after 48 hours. Also, the breastfed neonates may not be adequately hydrated until steady milk flow is established. So the first postnatal ultrasound is preferably done between after 48 hours, 3 to 7 days after birth. The usual ultrasound findings at after 48 hours would show one of the following scenarios. No hydronephrosis with normal pelvic calcium system, or unilateral hydronephrosis, or bilateral or unilateral with hydroureter, or bilateral hydronephrosis with bilateral hydroureters. These are the usual scenarios we'll encounter in the ultrasound findings. Coming to the approach, after performing the ultrasound within, we have to perform an ultrasound within 24 to 48 hours if there is a lower urinary tract obstruction, or between 3 to 7 days in other cases. So after performing the ultrasound, if there is no hydronephrosis, means SFU grade 0 or APD of less than 7 mm, or we have to see whether it is unilateral or bilateral, or lower urinary tract obstruction is there or not. If there is no hydronephrosis, usually we have to repeat the ultrasound at 4 to 6 weeks of age. If it is normal, no further workup is required. And if it is abnormal, we have to see whether it is unilateral or bilateral, and no lower urinary tract obstruction. If it is SFU grade 1 or 2 or APD of less than 10 mm and normal ureters, we have to do the ultrasound monitoring at 4 to 6 weeks of each, then every 6 to 12 months till resolution occurs. And SFU grade 3 to 4 or APD more than 10 mm and dilator ureters, the MCU at 4 to 6 weeks should be performed. If it is normal, and we have to do the renal dynamics scan, that is diuretic renogram at 6 to 8 weeks. And if VUR is present in MCUG at 4 to 6 weeks, we have to start the antibiotic prophylaxis. If the renal dynamics scan performed at 6 to 8 weeks show non-obstructive pattern, ultrasound monitoring till resolution is enough. And persistence or worsening of symptoms are there, we have to repeat the renal dynamics scan. If the renal dynamic scan suggestive of obstructive pattern with differential function less than 40%, consider pyeloplasty and antibiotic prophylaxis. If there is a feature of lower urinary tract obstruction, MCUG also should be performed within 48 hours. If it is absent and VUR is present, consider continuous antibiotic prophylaxis. And if lower urinary tract obstruction is present, we have to refer to a pediatric surgeon for further surgical management. Coming to the emergency measures, we'll review the emergency measures to be taken within first 48 hours after birth in infants diagnosed with antenatal hydronephrosis. The ultrasound should be performed in suspected urinary lower tract obstruction, example, posterior urethral valves or the prone belly syndrome, and bilateral hydronephrosis with or without hydroureter, and solitary kidney with APD more than 15 mm or SFU grade 2 or more. This ultrasound should be performed within 48 hours. And to consider antibiotic prophylaxis in cases of suspected lower urinary tract obstruction and APD more than 10 mm or SFU grade 2 or more in the third trimester, or solitary kidney with hydronephrosis of any grade, and also bilateral hydronephrosis. And BCUG should be performed in all suspected cases of PUV antenatally, and catheterization in suspected cases of lower urinary tract obstruction with PUV or prune belly syndromes. So according to the AAP, the incidence of significant risk of a postnatal pathological outcomes as mild is 11.9%, moderate is 45.9%, and severe antenatal hydronephrosis is 88.3%. So always counsel the parents regarding the increased risk of UTIs due to VUR and perform urine cultures for any fever without forget. Coming to the continuous antibiotic prophylaxis, the CAP therapy, parents to be counseled regarding the risk of UTI and need for prompt treatment. The indications of antibiotic prophylaxis is postnatally confirmed moderate to severe hydronephrosis or dilated ureter ureters should receive antibiotic prophylaxis while awaiting the evaluation. And also the prophylaxis in all infants detected to have VUR throughout the first year of life. The antibiotics that are preferred in India usually are cephalexin within first 3 months of life. And after 3 months, we can also consider cotrimoxazole or nitrofurantoin, according to the Indian Journal of Nephrology. And according to this Canadian Neurology Association, they have commonly suggested antibiotics are amoxicillin, cephalexin, or trimethoprim. Trimethoprim and cephalmethoxazole and nitrofurantoin, they should not be used in neonate because of increased risk of kernicterus and hemolytic anemia. So in a recent meta-analysis published in AAP, demonstrated that neonates with high-grade hydronephrosis receiving antibiotic prophylaxis have a significant low rates of UTI when compared to untreated neonates. While the rates of UTI were lower for the neonates with low-grade hydronephrosis, regardless of antibiotic prophylaxis. So coming to the surgical management, the indications of surgery is obstructive pattern on diuretic renography and differential renal function exceeding more than 40%, and also in infants with lower urinary tract obstruction and obstructed hydronephrosis after diagnosing the etiology, and also reduced differential renal function or its worsening on repeated evaluation, and bilateral hydronephrosis or hydronephrosis in solitary kidney showing worsening dilation and deterioration of functions. And other indications for surgery include presence of pain or palpable renal lump or recurrent febrile UTIs. The usual surgical management of ureteropelvic junction obstruction is dismembered pyeloplasty, and this has reported a success rate of 95 to 100% with a high level of evidence. Although renal function might change several years after surgery, it has been reported that renal function stabilizes within approximately 5 years and is maintained for a long time thereafter. According to Lee et al., they reported the development of renal complications such as hypertension and proteinuria even after 15 to 20 years after the surgery. And the other common finding is PUV, posterior urethral valves. Usually, valve ablation is an ideal approach. Even after ablation, there is persistent obstruction or recurrent UTIs. We can consider vesicostomy or shunting. The take-home message is all significant antenatally diagnosed hydronephrosis, especially in the third trimester of APD more than 7 mm, should be investigated with a postnatal ultrasound. The role of continuous antibiotic prophylaxis initiated at birth is controversial, but may be of greater benefit in grade 3 and 4 hydronephrosis and in cases with dilated ureter or bladder abnormalities. The VCUG is not necessary in the evaluation of isolated low-grade hydronephrosis with normal renal parenchyma and symmetric renal size, but it should be investigated in high-grade hydronephrosis with SFU grade 3 to 4, followed by a diuretic renography if the hydronephrosis cannot be explained by VUR. The diuretic renography is not necessary in the evaluation of isolated low grade with normal renal parenchyma and symmetric renal sizes. Thank you.
Thank you, Radha, for the excellent presentation. Participants, if you have any particular questions to ask her, please go ahead. I did not see any particular question on the message section. So I guess, again, to summarize what Radha said, that antenatal hydronephrosis is quite a common finding in the antenatal scans nowadays, and most of them will go away with time on its own. But it's very important not to miss the persistent ones, and very important to retain them in our follow-up. And if necessary, we have to do all the scans that is required in close consultation with nephrology and surgery as necessary. It looks like you have quite clarity in your presentation. There is a question: what is the age recommended to do pyeloplasty in case of PUJ obstruction? Radha?
As we discussed, if it is a lower urinary tract, bilateral obstruction, lower urinary tract with significant renal parenchymal damage, we have to do the procedure immediately because the renal damage can be permanent.
Yes, in most of the cases, the surgeons will probably be pretty prompt based upon what the findings are.
It depends
Next.
upon the diuretic renography and extent of renal damage. If medulla is involved, we can follow up conservatively. If cortical thinning and parenchymal damage is there, we have to intervene as soon as possible.
Okay, looks like there is no more other questions right now. So thank you for your talk, Radha. And Dr. Samad, with your permission, we can close the session.
Yes, sir.
Okay.
Okay, so
Good
thank you.
weekend, everybody.